This video discusses using the NICOM monitor during 3 surgical procedures. The first case presented is that of a 58-year-old female who was scheduled for a laparoscopic hemicolectomy. She is otherwise healthy with no other significant medical problems. Her preoperative blood pressure was 140/85, and she was not taking any antihypertensive medications. A balanced general anesthetic was provided with endotracheal intubation, and the surgical procedure was completed in 2.5 hours. Her estimated blood loss for the procedure was 150 mL, and she received 750 mL of Ringer's lactate. Her hemodynamics were stable throughout the procedure, as indicated by our standard anesthetic monitors and the Cheetah NICOM monitor. The nurse called 1 hour after she arrived in the recovery room to state that her blood pressure was 75/40. The patient otherwise felt well, her heart rate was regular at 83 per minute, and her saturation was 97% on room air. A 500 ml IV bolus of Ringer's lactate was ordered, and a blood sample was sent for hemoglobin and a base deficit measurement. 1 hour later, the nurse reported that her blood pressure was somewhat better. Her hemoglobin was 110, base deficit -1, temperature 35.9, and the patient's urine output was 150 ml since arriving in the recovery room. The NICOM monitor was then brought into the recovery room and reconnected to the patient. The NICOM monitor was turned on and the patient was recalled from the existing patient roster so that the patient's previous demographics could be immediately recalled. Her NICOM monitor data confirmed a relatively low blood pressure of 92/53. Her cardiac output, which is a product of her heart rate and stroke volume, was normal at 5.8 liters per minute. The cardiac index, which is her cardiac output divided by her body surface area, was also reported and was normal at 3.8. Her stroke volume index was 45, which is also in the normal range. A stroke volume index of less than 30 would suggest that her heart was underfilled and has been used as an indicator of fluid responsiveness. Her total peripheral resistance calculation is similar to the calculation used for systemic vascular resistance, but assumes the contribution from the CVP is negligible. Hence, the TPR is equal to 80 times the mean arterial pressure divided by the cardiac output. The total peripheral resistance index is the TPR divided by the body surface area. The normal TPR index is approximately 2000, so for her size, her TPRI was relatively low. The normal TPR is approximately 1000. The stroke volume variability is also reported. An SVV of greater than 10% suggests the patient may be volume responsive. However, to be a valid indicator of fluid responsiveness, the patient must be in sinus rhythm and on a ventilator. So in this case, it is better to rely on the SVI as an indicator of whether or not the patient is likely to respond to fluids with an increase in stroke volume and cardiac output. So how do we interpret this data? It appears that despite a relatively low blood pressure, the patient's cardiac output is adequate. We know her hemoglobin is normal, so her oxygen delivery should be more than adequate. She has a relatively low peripheral resistance. These hemodynamics could be seen in a patient with a functional epidural block. However, she did not have an epidural or spinal anesthetic. It could also reflect a patient with an infectious or inflammatory response. However, her temperature remained normal. Her clinical condition did not suggest an allergic response, but this should always be entertained in a patient with a relatively high cardiac output, low resistance, and low blood pressure. Her blood pressure normalized over the next several hours, and she was discharged to the ward without further treatment. In the end, we concluded that her hemodynamic abnormalities were likely due to an inflammatory response related to the surgical procedure. The second case is that of a 75-year-old female who was scheduled for a laparoscopic colon resection. She had a past history of paroxysmal atrial fib associated with congestive heart failure 1 year ago. Investigations at that time revealed significant aortic stenosis for which she was medically optimized, and she has been in sinus rhythm since optimization. Her previous booked procedure was abandoned after failed intubation attempts under general anesthesia with both direct and fiber optic intubation. After establishing an arterial line and applying the NICOM monitor, a fiber optic intubation was performed with topical anesthesia and IV sedation. During her procedure, the intraoperative monitoring showed a normal sinus rhythm of 57 per minute with a stable blood pressure and a stable level of end-tidal anesthetic agent of 4.6% desflurane. Her cardiac index was 2.6, down from 3.2 in her awake state, and her stroke volume index was normal at 43. Both her stroke volume index and stroke volume variability suggested that she did not require additional fluids. Her peripheral resistance was slightly higher than normal, with the normal TPR index being about 2000. 15 minutes later, her hemodynamics by our traditional monitors were unchanged. However, her cardiac index had decreased from 2.6 to 2.2, and her peripheral resistance had increased significantly to approximately twice normal. The trend of her stroke volume and heart rate revealed a progressive reduction in stroke volume, accounting for the decrease in her cardiac index. After 70 minutes of insufflation, there is a significant further reduction in cardiac index accompanied by a further increase in peripheral resistance. In 1995, the CJA published a review of cardiopulmonary effects of laparoscopic surgery. The effects of peritoneal insufflation, which were based on studies of patients who had pulmonary artery catheters inserted for elective cholecystectomies, demonstrated that insufflation resulted in an increase in mean arterial pressure accompanied by a 50% reduction in cardiac index in healthy patients. Typically, a biphasic pattern is observed during laparoscopic CO2 insufflation with an initial progressive depression of the cardiac index accompanied by a rise in mean arterial pressure and systemic vascular resistance. Partial recovery occurs over the next 15 to 30 minutes, primarily resulting from an increase in CO2 absorption and hypercarbia, resulting in a release of catecholamines such as dopamine, vasopressin, adrenaline, noradrenaline, renin, and cortisol. Laparoscopic insufflation of CO2 is usually well tolerated in healthy patients, but may not be tolerated for long periods of time in patients with limited cardiopulmonary reserve. The activation of the cardiovascular system with release of endogenous catecholamines associated with CO2 insufflation can result in an increase in arrhythmias and vasoconstriction of the pulmonary vessels. Left ventricular wall tension increases as mean arterial pressure and systemic vascular resistance increase, and this may result in regional wall motion abnormalities and ischemia, especially if accompanied by tachycardia. The associated reduction in cardiac index may result in insufficient tissue oxygenation and perfusion, with a drop in mixed venous oxygen saturation and an increasing base deficit. Effectively, the abdominal insufflation creates a temporary intra-abdominal compartment syndrome or visceral tourniquet, compromising mesenteric and renal blood flow. Like other tourniquets used during surgery, it is generally tolerated for limited periods in healthy patients. However, unlike applying a tourniquet to a limb, the gut is a much more sensitive organ. With release in the CO2 insufflation, there is an immediate and dramatic increase in cardiac index and stroke volume, accompanied with a reduction in resistance. The NICOM monitor allows the surgical team to appreciate and understand the underlying physiological changes resulting from prolonged CO2 insufflation. This understanding can be critical in patients with limited cardiopulmonary reserve. Some clinicians would argue that this monitor just adds more information and stress to the day without changing anything. However, for the clinician who wants to understand the underlying physiology and the implications of prolonged CO2 insufflation, this information allows them to communicate with the surgical team about the patient's well-being, emphasizing the importance of not wasting time, minimizing the insufflation pressure and degree of tilt in the bed, and optimizing relaxation, as well as entertaining the need to take an insufflation break during the procedure or to convert to an open procedure. The third case is that of an 85-year-old man with a ruptured abdominal aortic aneurysm. He presented in a collapsed state and was intubated at a peripheral hospital and transferred to our hospital on norepinephrine. There was minimal history available, although an INR result from the peripheral hospital was 4, suggesting that he was likely on Coumadin. The odds for this patient are stacked against him in that he has to survive the initial rupture, the transfer, and the operation, with each of these stages associated with a mortality risk of approximately 50%. Other significant risk factors for this patient are his age and his coagulopathy. He was brought urgently to the operating room and an urgent laparotomy was performed to control the rupture. An arterial and central line was placed along with the NICOM monitor, and the patient was given Octaplex and vitamin K to reverse the Coumadin effect, while additional blood product support and the use of a cell saver and point-of-care testing directed ongoing therapy. An aortic cross clamp was applied, and 40 minutes after arriving in the OR, he had been weaned off his vasopressors and had a heart rate of 54 per minute, a blood pressure of 119 and 68, a saturation of 100%, and a temperature of 35.5. While these hemodynamics look good on first impression, the NICOM monitor data provide a more in-depth analysis of his current state. His cardiac index is low, his stroke volume index is low, and the stroke volume variability is high, all suggesting he would benefit from additional intravenous fluids. The patient had received fentanyl, midazolam, and rocuronium. His peripheral resistance is approximately 2 times normal, which is to be expected with an aortic cross clamp on. However, his end-tidal anesthetic agent is low, so his resistance may also be high secondary to a light level of anesthesia. With this information, the interpretation was that he was fluid responsive and that his resistance is high secondary to the cross clamp and or a light level of anesthesia. As additional fluids were administered, His cardiac index and stroke volume index improved significantly, although his stroke volume variability continued to suggest that he was still fluid responsive. Additional fluids were given, and his depth of anesthesia was cautiously increased. Blood for point-of-care testing was performed to help guide his care. The information provided by the NICOM monitor was crucial in managing this patient and understanding whether fluid or vasoactive medications were needed. The patient was transported to the ICU at the end of the operation, hemodynamically stable and not requiring any vasopressors.